This is our 9th annual UCSF Global Child Health Lecture Series. And I'm excited to invite back Dr. Joshua Bress. He's a neonatal hospitalist, there we go, and president of the nonprofit organization Global Strategies. He graduated from medical school at Vanderbilt and completed his pediatric residency here at UCSF. So he's also an alumni from the program. And his primary interest is how to make it easier for doctors, nurses, and midwives to follow clinical guidelines. And one of his primary roles at Global Strategies is as the medical lead on NovaGuide, which is a clinical decision support platform. So really excited to have you here today and to hear what you're working on.
Okay, thanks so much. I'm going to go ahead and share my screen here. And I think I got to figure out a way to get the chat open as well. 1 second. Okay. All right, well, nice to see everybody, and thank you again for the invite back. It's been a real pleasure to be part of this lecture series. It actually always comes in September for us, and September is the beginning of our fiscal year. So for us, a bit of a New Year's tradition. And what I tried to do is just bring to the group something we're just working on, something that's like on the front of our minds. And so today we'll be talking about safety and errors in digital health. I can't see everybody here. I know not a lot of Zoom lights on, but I don't know to what extent your work involves digital health, but this session will be a little bit interactive. So even if you don't have your Zoom light on, I would tell you to pull open the chat so you can drop some answers in. The first thing I need to convince you of, I think, is why should we be talking about software errors in a pediatric global health lecture? So I'm going to go through 3 slides to kind of make my case, because I'm very worried at the end of this that people will fill out their evaluations and say this is just not relevant at all to my work in tuberculosis or malnutrition. The first is what I see as the Venn diagram for global health and digital health. If you're involved in global health, you will be involved in digital health. Digital health will be the way that you achieve global health aims. So it's critical to be having digital health lectures sort of mixed in. The second thing is, I would say, know your tools. I don't know the background of everybody on this call, but maybe a show of hands on the Zoom. Are people in clinical medicine? Okay, there we go. Some thumbs up. Okay, great, perfect. People are out there. So I think of this as that maybe lecture that a respiratory therapist would give to you about the ventilator. You're not going to be asked to fix that ventilator. You're not going to be asked even to maybe explain it to somebody else, but you still need to know enough about it to do the job that you are trying to do. The last part I'll say, and maybe this is one of the key learning points, is we all use software in our daily lives, and we all use it, I think, in our global health work. There's a huge difference between those 2 types of software. The software you and I use if we're living in the United States to get to work using Google Maps or to make a reservation for an airplane. These are softwares that are made by very, very large companies that have invested millions, sometimes billions of dollars to make sure that it always delivers exactly what the customer wants. And this is simply not that. In global health, you're going to find software out there that maybe was the very first software product an individual made. Maybe they made it as a student project even, and they've never worked in the workforce around software. This type of software just needs a special critical lens. Okay, so I'm going to start with a warm-up case. So get your Zoom chat ready. Fortunately, I started with a case that has absolutely nothing to do with software, so it's a light one, and I'll just read it out loud for you. There are 2 children in the emergency department with the same last name. That last name is Williams. There have been staffing problems this month, and the same nurse is assigned to both children. One of the children is here for a simple upper respiratory tract infection. The other has an ear infection. But by accident, the nurse administers the antibiotic that was ordered for the second child to the first child. And the error is discovered when the mother of the second child asks, is the antibiotic ready? Maybe throw in the chat. Tell me, when you see a case like this, what do you think what do you think about it? What do you think caused it? Or you can also just raise your hand and say an answer out loud. What do you think when you see a case like this, people in clinical medicine, what jumps out to you, or if someone said, like, what was the root cause of this error? How did this happen?
I think about I think the model I think of is called the cheese hole model, I believe, but just like all of the structural level things that led to this. So the fact that the ED was understaffed that day, and that this nurse was assigned to both children with the same name, and maybe something with how medications are administered without there being some kind of warning flag.
Okay, great. That hit like a lot of them. And I see Marone added in that this is a system error, that things should be kind of in place to protect the provider, maybe from making this mistake. And what I'd like to get across with this example is like, we have a framework for this. Someone even mentioned like an actual real framework for this to think about errors. And some of the hallmarks of those frameworks are you don't necessarily go blaming the individual, that the goal of this is to prevent maybe the next case from happening. And in this, you often look for things that were external to the provider. You know, for this specific case, I think, yeah, the staffing, right? But I also think about all the systems we have for name alerts, right? There should be a name alert on the outside of the door. There, when the nurse scans the band, it should, that should be part of the standard procedure for confirming a medicine. So what I'm hoping we can do here is look at a bunch of digital health, global health, real world cases, software errors, and apply that medical errors mindset to these examples. And the goal here, I think, is to help you really develop a critical mindset when looking at digital health tools. And when you apply these digital health tools in your own work, even if it's not in the specific area that we work in, which is clinical decision support, helping clinicians make decisions, that you'll still find this toolkit just generalizable to any digital health work that you are involved in. I took something I learned from my wife, who's an elementary school teacher, to kind of differentiate this learning around beginners. Maybe you've never thought about software errors. Maybe you've never found one. Maybe you've never seen one in your own hospital work. Maybe intermediate level. I think of this as kind of the intern. It's like, I've seen a few cases and I have a framework, early developing my mental model, all the way to an expert, someone who's like hunting errors for their job and knows how to find them and knows what to do. Maybe you might think of as like the risk management group for your hospital who's really focused on trying to prevent these errors. But because it's peds and child health, we got to bring in some animated characters to help us out. So I created these kind of 3 characters. I ran them by my 2 daughters and they were just completely approved. And so these characters are going to kind of represent these 3 tiers of like, I've never thought about this. I'm just learning this and I'm an expert at this. And they'll help us populate this amazingly animated toolkit as we go through this, okay? I see some applause on the Zoom for the animated characters. Okay, so let's go ahead and look at some errors. And you can remember, you can jump into the chat as well. So I'm going to start with a light one. And in most cases, I would say I've hidden the user interface, meaning you're not going to be able to figure out whose app this actually was. And that's on purpose, because just like the medical errors, what you're trying to do is not blame the individual, but look for how this could have happened and how you could prevent it. Okay, here's one. So this is a COVID screening application. This was internationally available. And putting in this case, I said I'm an 87-year-old. I have a cough and a fever. I've been exposed to someone with a cough and a fever in the last 2 weeks. I have a headache. I have a sore throat, and I've even lost my sense of taste and smell. Answer, I definitely don't have COVID. Phew, thought I was gonna have it there. So it says no COVID infections appear to be present at this time, and I also have no breathing problems. I forgot to mention that earlier in this application, I had said my breathing was actually fine. I had been exposed. I was 87-year-old exposed, lost my sense of taste or smell. So you probably never thought about software errors. Maybe you've never seen an error like this, but maybe someone could just describe this error. Like, what was the error? Or maybe someone can suggest a root cause. Feel free to just jump it in the chat. I know we have at least one software developer from my team here, but I think everyone else, I'm not sure that your background in software, but how do you think something like this could happen, or what happened?
Might have been that in the symptoms, even though you had a collection of symptoms, certain ones have to be checked for it to come positive, like a cough, for example.
Okay, I like it. So that it was looking for a cough and it didn't see it. That's right. You're onto something, because I didn't put in a cough in this case. Anybody else? How do you think something like this could have happened? Any ideas? Can we all agree that it should have said very concerning for COVID, right? Loss of sense of taste of smell, sick exposure. Okay, I think we got enough to move forward. So this will kind of get you a flavor for this. So how do people think about this? I would say the junior person, if you never looked at an error like this, it's just good to just describe what the error was, right? I said I had a sick contact, I said I had a headache and a sore throat, and I lost my sense of taste and smell, and I probably have COVID, right? So this was like, it was just what should have been true was labeled false. The app told me I definitely did not have COVID. It didn't even suggest like that I maybe could have had it. And the fact that it happened in an 87-year-old feels relevant. Maybe quick poll, does it matter that it's an 87-year-old? In this case that I showed you. Okay, I see a nod from some of the people with the Zoom light on. Any thumbs ups? Yep, okay, someone's saying yes, it matters. Okay, people saying, yeah, I actually also agree that it matters. It matters in this case for a reason. You may not know what the reason is, but we'll reveal that as we kind of go through. Okay, the second, more experienced error hunter detective says, people know that no smell equals COVID. So this is not a knowledge gap. This is key, right? In medical errors, where one cause of an error is that you didn't know. You didn't know that no smell equals COVID. But this error hunter says, I doubt that's the case. It feels like a testing error, root cause. So you wrote the essay, but you did not proofread it. Had you proofread this, you would have caught this. This was the root cause, that you didn't read your essay, you didn't check it. And the 87-year-old is relevant. And this detective kind of highlights why it might be relevant. It's relevant because of something that they're going to call hazards, which we're going to get into. But a hazard is what could go wrong. And what could go wrong is like exactly this case, right? This would have not been as bad if it was in a 5-year-old. But the fact that it's in an 87-year-old just is worse. It's a worse hazard. And then let's look at our expert. Our expert, again, also acknowledges that this is not a knowledge gap. And what that means is that the people who had the knowledge couldn't see it. This is a key part about software that's different in some ways from medical errors, is that the people who make software are often not going to be the same people who are medically trained. So one common cause of errors is that the people who are medically trained can't see the software in a way that they could have detected this error. This person brings up a key, or this mouse brings up a key point, which is errors always exist. I believe that myself. And so what you need is a system for detecting them. Show me how you detect them. So this is, you can imagine like in the round table where you're looking at how did this happen? This expert would be like, show me how you detect the errors right now. The hazard here was unacceptable. So someone decides here, this hazard was like so hazardous that it was unacceptable. We'll talk about that. And what this means is you shouldn't have thought about hazards. You need to notify every single person who used this application. Spoiler alert, you're not gonna be able to do that, and probably take it down. So what kind of things does this case bring into our toolkit? Well, the first thing is that medical errors, not everything, like medical errors, not every software error is a knowledge gap. Like if only they had known that, right lower quadrant pain is an appendicitis, they would have picked that case up. We know that that's rarely the cause of a medical error, and it's often rarely the cause of a software error in a medical digital health world. The second two are related, which is testing and how you test matters, and the errors are going to exist. So you have to kind of proactively think about, okay, so I've made my application, or someone's asking me to use this application. How did they test for errors? You never want to assume that they never had errors in the first place. So when I see a new software, one of the most common questions I ask myself is like, so how did you test this? How do I know that it's going to deliver the output that you said? And the last is hazards. And so I'm just going to kind of take a quick detour to introduce you to this world of hazards and make you kind of more expert at detecting errors in these projects. Hazard analysis, there are books written about this, but I'll just do one slide. And that slide is this. What could go wrong? That's the hazard. How bad would it be if it happened? 1 through 5. Rank it. How likely is that to happen? 1 through 5. Rank it. And now the hazard score is like a quantifiable measure of how bad the hazard is. Okay, so we can apply this framework to our case. How bad would it be if an 87-year-old is told they don't have COVID when they definitely do have COVID? 5. That's easy. Like the more you look at this, you're like 5. That's just horrible. How likely is that to happen? 5. You could easily imagine someone with this case being put in. It's not that unusual a case. It's not some zebra case. So how bad is it? 25. It's unacceptable. And there are actually measures around these numbers to say like, a number above this is unacceptable. And you must now show how you're going to mitigate it, either to make it less likely or less bad. Does that make sense? So when I look at a software, my second question is, show me the hazard analysis for this software. Like, did you think about everything that could possibly go wrong? I'll tell you, in global health, you're rarely going to find these. So the tools you're using maybe haven't gone through this sort of formal process of thinking about what could go wrong. Okay, here we go. Another case. These are getting harder. So if you had trouble with the COVID one, you're going to have to get a cup of coffee. So this is a app used in pediatric emergency care. And I put in here that on the top left, the child is not breathing. It asked me to clarify. So I said that it's none of those. It's not choking and it's not trauma. It instructed me to bag mask ventilate. And then it asked me what happened. And I put down that the child did not resume spontaneous breathing. Okay. And then down here in red, this is what the application told me. Absence of return of spontaneous breathing. If the child does not begin to breathe spontaneously after the first maneuver and after 15 minutes, inform the family and stop the resuscitation. Okay, tell me what you think about this. This is the actual app would tell you this. Does anyone think this is a problem? Okay, see some nodding, maybe hands on the Zoom. Yep, okay, see some nodding. Okay, so can anyone attempt to just describe why they think it's wrong?
There's no world in which they would only do 15 minutes of resuscitation on a child that was down.
Okay, so maybe the content, right? So they didn't get the guideline right. Okay, how about another one? Anyone else? Why do you think, what do you think about this? Does anyone think it's fine? No one seemed to think it was fine. Any other ideas about, okay, so here we go. There's no option to escalate care, okay? See that in the chat? Okay, any others? This one's trickier. Okay, pulse. Okay, I was waiting for this one. Okay, yep, that was one I came up with myself. I was like, oh, if they have a pulse, I would be a little hesitant to maybe breaking the law to not continue this a little bit longer. Okay, so let's go through this. So I would say bonus star award for Barbara on the call. So I came up with the same one around the pulse. So I'm not sure, this feels like an error. Maybe this is how some of you are feeling. Like it feels wrong to see an app tell you to stop breathing for somebody. The intermediate person comes up with this example of the heart rate. Okay, so the error is that you stop the ventilation without any mention at all of the heart rate, and then comes up with a case that could match this, right? Like a child gets into pain medication, a child got too much anesthesia. If you think about this, like every child under anesthesia would meet this criteria. So you can come up with a case. And the intermediate person comes up with like a root cause. The root cause is you didn't think of the edge case. Or just bookmark that. That's going to be like our hazard analysis, another term that we can use to think about errors, where a child might require ventilation for more than 15 minutes and still live and maybe even be fine. The expert is much more concerned about this example. And an app telling me to stop life-saving measures, like we're concerned about self-driving cars. This is much, much worse in terms of just to stop an active resuscitation. The expert also is familiar with the edge cases, but goes back to this is about the hazards. So it's like how did this get in here? How did any app tell you to stop breathing for a child? That should never be something maybe an app should tell you. Maybe an app, you can imagine another way to put this. If it's been 15 minutes of ventilation, things to consider are the following, and never give a direct instruction to stop breathing. Okay, so let's bring in some new terms here. So the next is an edge case. An edge case, the way I think of this is probably more of a software term, but an edge case is sometimes called a corner case. This is like the unlikely case that you still need to somehow account for in your software, okay? In medicine, we would call this the zebras. And in the United States, you call it a zebra, right? It's like the uncommon one, the one that was not like all the other ones. And again, we have this return to the hazard analysis. When I get a piece of software that's I've never seen, and someone tells me can provide some clinical recommendation, one of the very first things I do is just feel out the edges. So you can imagine, like, if I get a bilirubin application, the first thing I'm going to try is, okay, what if I put in that I'm 1 hour old and my bilirubin's 100? Okay, did they like think about that? Did they think about some strange case one of the things it tells me is like they thought through this. Like, I just like to see that they thought about this in case it gives me more confidence that they have looked at other aspects of the application. If I can put in like 100-kilo baby into your baby application, I'm like, I don't trust you anymore because you haven't thought about some of the real basics of software design, and it gets harder and harder and harder. I'll give you some examples of edge cases we encountered in our own work in global health. One is in a baby application around oxygen saturation monitoring. So baby comes out, the baby is in respiratory distress. You have an oxygen saturation monitor. You apply that oxygen saturation monitor and it's less than, let's say, 88. We had like one of the edges, like, well, what if it was like a case of congenital heart disease in a patient who also had respiratory distress? How would we kind of guide the user through that? Another example in similar around congenital heart disease is like a well-appearing child who has a saturation of 75. Are we going to say that that's who's not breathing hard, I guess I should say? Are we going to direct them to a congenital heart disease pathway versus prompt them to rethink it? These are the kinds of cases that you're going to have to wrestle with, and edge cases are a common cause of errors, as we'll see. Okay, hopefully everyone else is getting warmed up for some more. So this is another application. Here we go. I put into the application these parameters. I've got a child who's 2 to 3 months old. They had 1 or more convulsions during the present illness. The temperature was 32 degrees. There was no history of fever, cough, abdominal pain, diarrhea, or a skin problem, and they had a runny nose. Okay. Diagnosis? Anyone want to hazard a diagnosis? Well, it definitely is not going to be this one. Cold. Okay, so the child has an upper respiratory tract infection. And that's what this is an app that's been used many times. This is what I was able to get it to give me back. Any ideas from the group? What is the error, and how could this possibly happen?
I'd be concerned for sepsis without low.
Right. It's like, okay, you'd be concerned for sepsis. You'd be concerned for like something much more serious than an upper respiratory tract infection. So the error here is like the misdiagnosis, right? Which is a medical error also. So there's maybe some similarities. Any idea of how something like this might happen? Feel free to just drop it in the chat or.
Well, the vital signs are free text entry, right?
Okay, here we go. Okay, so vital signs. So yeah, the vital signs in this case were free text entry.
So is this really 40 tube? Although they said no fever. Yeah. You kind of like look at
So was it an error? Yeah, so like, did the person mishit and put in like 32 when they meant to put like 38? Even if they did that though, even if it was a mishit, it shouldn't still tell you then it's a cold. So it could have been that there's an error there. But I think you're onto something with the vital signs. Anybody else have any thoughts on this one? Like, if you were trying to explain to your first-year medical student why this is not a cold, maybe that's a way to start.
Are there other vital signs?
Yeah, so like vital signs. Like, vital signs is why this cannot be a cold, right? Or it can't be a cold. With 32 degrees, it's like it's very hard to imagine someone walking out of the emergency department with a diagnosis of URI with a presenting temperature of 32 degrees Celsius. And the convulsions, right? So there's not a lot of colds. They'll also have a seizure and they're going to leave with a diagnosis of a cold. Any idea how this kind of error can get into a software?
there like a hierarchy when you guys are in the software in terms of what
Yeah,
becomes more
okay, here we go.
important?
So yeah, is there a hierarchy? I could expand on that a little bit.
So for example, it's kind of like anchoring, it's like the anchoring bias we have as clinicians too. It's like anchoring on maybe the age and rhinorrhea more importantly than the convulsions and the temperature.
Okay, that is like very close to like what I came up with myself and like looking at all these areas a long time. Okay, so let's go look at kind of these three levels. I think you've all kind of hit the whole range here on errors. So the junior person would maybe say, look, the error was that it seemed to only see the rhinorrhea. Okay, so it was like it saw rhinorrhea and went with cold. And that maybe it didn't recognize that the temperature of 32 was really far off. It was looking for a fever. So I'll just tell you, hypothermia in all the apps that you may be using, it's rarely going to be flagged, even though clinically we know that it's like a major presenting cause of sepsis. So, and that's often because it's not in the source material that they're pulling from to get this. So you can imagine like danger signs for sepsis, fever greater than 38 degrees. That's going to be one of them, right? And it rarely is going to say in that same guideline or temperature less than 36 rectally, or whatever it is. It's rarely going to be in the source material. So this is like oversimplification of the source material is one way you get this, and then the app just translates that. So the app, there was nothing in the paper that said, hey, if it's 32, like don't call that a cold. So they just directly digitized it. That's one way you could get this kind of error. Okay. The next thing is vital sign logic, which people are kind of circling around here, but I'll just make it more simple. Vital sign logic is super complicated. So if you have vital sign logic in your application, you better make sure you have a system for checking for errors, because it's just going to get really, really tricky. Like I'll give you an example. There's no symptom that I can't totally mess with by changing the vital sign. So, I have a headache. Okay, now I have a headache and hypotension. It's like, okay, well, wait a minute. Now the headache is like completely different than it was before you told me that other piece. So the vital sign logic is like very, very complex. And maybe the people who made the app just like got into it, not really thinking like that, thinking like, oh, greater than 38 equals fever, and that's a sign of sepsis. So in one way, the vital sign has to override things. So a temperature of 32 has to just like override, and I would just say delete the rhinorrhea. It practically, it's going to have to delete the rhinorrhea. The clinician has already deleted it in his or her mind. Like, okay, yeah, you told me you had a cold, but like, let's go back to like, why did you get so freezing cold? They're just going to completely maybe the rhinorrhea maybe never comes up in a real world clinical encounter. So the vital sign is this giant weight. And whenever you put in it, but we need them. So whenever you see vital sign logic, we'll have a couple more examples of this. It's just going to be a very, very, you're all of a sudden you went from like, oh, I'm climbing a hill to like, I'm climbing a mountain. And did you bring all the tools that you needed to scale that mountain? Convulsion, same thing. It's like, if you tell me that the illness caused a seizure, it's like, okay, well, you just like eliminated a whole bunch of illnesses that it can no longer be. You can't leave with that diagnosis. And let's go into the expert. So the expert says that the root cause is how you manage the complexity, knowing that you see vital signs, like, oh, this is going to be a mess. And now, sure enough, here we have one. And there are design decisions that you can do. So the expert may think of some solution to this vital sign problem. For me, one of the best guides for your digital tools is just to think like you do clinically if you practice clinical medicine. So if you saw that temperature of 32, you'd be like, let's get a blanket in here. And you're doing things and you're acting, and you're not going into like the review of systems yet, where the rhinorrhea would maybe surface. So the clinical interview is not a form. This is like a key thing where digital tools are very good at making forms. Like, hey, let's go in and fill in all of our data pieces. And oh yeah, you had rhinorrhea. Where the clinical interview is much more dynamic. So the expert says that the real root cause of this is how you manage the complexity, and you needed branch logic. You needed a logic that said like, whoa, extreme low temperature, we're going to like this other branch that's very far from my upper respiratory tract infection branch, and so I never touch it. And maybe I never even ask about the presence of rhinorrhea. Okay, so two causes of errors, and I would say these are kind of related, is branch logic is how we think in medicine. Okay, so we are trained, like highly trained, to just like go through crazy branch logic in our heads. And some of it, we don't even recognize that we already have it in there. Like, I'll give you an example. It's like 5-year-old boy comes in with abdominal pain. In my brain, I don't have to think that I know it's not a pregnancy-related cause of abdominal pain. But my brain knows that. It's made a branch and it's like completely cut that branch off. It's like, okay, we're into like a 5-year-old. There's nothing to do with that. And yet the computer is not as smart as that. The computer often think in forms, like fill everything you have out. It's why symptom checkers are just like not great at like coming up with a diagnosis, because they don't have this kind of underlying branch logic. So I would say that one of the things you can look for in your own digital health, global health work is like markers of complexity, the same way you use in your clinical mindsets. Like, oh boy, red flag, like this thing has vital sign logic. I just know it's going to have a problem. Or I know they better have, like, I need to know how they've solved these problems is another way to put it. Okay, here's another one. This one may be a little easier, so let's go for it. So this is a pediatric app, widely available, and had a dose of neonatal gentamicin that was, if you're less than 7 days old and if you're less than 2 kilos, the dose is 3 mg per kg. This is slightly different than our US guidelines, but these are this similar to the WHO. But the WHO guidelines, which this app claimed to be representing, actually has that weight band go all the way up to 2.5 kilograms. Okay, so now this was essentially like an overdose for everybody between 2 and 2.5. Does that make sense? Okay, what do you think of this kind of error? Or anything that jumps out at you now that you've gone through 3 and you're getting into that intermediate level? Are there things that you're like, oh, jump out to you? How do you get this kind of error? Any ideas? I see some quiet people on Zoom. We've had some people carrying us, but any ideas in the chat? Any like, think there's a common error? Yep, there are more weight categories in the WHO. I see someone chiming in here. There are more weight categories, different weight categories. And I should say that the way the WHO does this is in the paper guideline, but it's actually very unfamiliar to the way we would do this, and you would do this at UCSF, right? It's giving you the milliliters. So what it's doing is trying to do the math for you to say, look, if you were 2 kilograms, you'd be doing 0.6 milliliters of this gentamicin. And so these are for settings that maybe don't even have calculators. That's how the guideline is designed. So you're not getting like an exact dose. You're getting kind of a range of doses. You're picking, some of these it's hard to get on the syringe, but you're picking something between 0.6 and 0.75. Maybe thinking about the vital sign logic. Are there things that like invite errors in this? We know that drug dose errors, right? These are in pediatrics. These are common medical errors. Any ideas of why they're super common medical errors? Okay, all right, here we go. Someone came in with one of them. Okay, so it also did not include the child who's exactly 7 days old. Okay, this person is getting into intermediate level. So that is related. I'll say they did not include someone who's exactly 7 days old. They also did not include someone who's exactly 2 kilos. Okay. So what's the cause? This is kind of like read my mind, so I'll just keep going. The error is drug dose error, okay? And that's the junior person. It's this, okay? Just like vital signs are associated with errors. If you have weights greater than, less than, or equal signs, you will have errors. Okay, you will have errors. You're gonna have to hunt those errors out and weed them out, because the chance that you just like make like a tiny mishit is just everywhere. So yep, just like Marone mentioned, it did not include the 7 days. It doesn't include the 2 kilos. And I've seen it hundreds of times. I've seen it thousands of times. Okay, this is just everywhere. Anytime there is a greater than, less than, or equal sign, you just know it's going to be errors everywhere. Errors everywhere. And the worst, of course, is like the flipped sign. You know, the less than when it should have been greater than, or one or the other. Okay, but let's get into like the next level, because we've looked at, 4 or 5 errors here, but let's like take this up another level, which is, okay, the expert says, look, I get it. It's greater than, less than, or equal to, and this is like the bread and butter of error detecting. right? Like if I said like, put my money on an error, I'm like, okay, I'm putting it all on the greater than or equal to, that's going to be like, I know I'm going to find something there. But what the expert brings up is that when a guideline changes, it's actually the inverse of this exact thing. So, okay, let's say that the guideline changes. I give this example here from Peds. Like, let's say everyone's giving gentamicin 5 milligrams per kilogram every 24 hours. And now the entire world agrees to 5 milligrams per kilogram every 36 hours. Suddenly, your old version is an error. This is like another way of thinking, but your old version is an error. So you have errors that are hiding and waiting to be revealed upon the change of the guidelines is like another way to think about a lot of the software that you're using, right? So we've gone through this, right? Like Billy Tool had to change when AAP changed its own guidelines. What did Billy Tool do in the interim, right? Billy Tool had like put out a warning saying like, okay, we're working on it. We're working on it. If you need the old one, go here, but like we are working on this. So one of the things that this brings up is like, well, what is your system? Like, what is your system for like if suddenly something in your application is off, is off? And what if you think of like an extreme case? So let's say we find out like there's an extreme case and gentamicin should no longer be given to children. Okay. How would you get all those gentamicin apps down? How could you get them down? This is something we think about in our own work. So I'll give you an example from our own work is that in our own work, we have numerous applications. And one of the most common questions we get is, does it work offline? Right? And everybody knows it has to work offline. Otherwise, it couldn't be used in global health. But you now are setting yourself up for this problem. So what's going to happen when the guidelines change and you have all these offline versions of your software just floating around out there? And what if there was like an actual real reason to pull it down? And you can imagine COVID was, in many cases, that reason, right? COVID was one of those things, like all of a sudden, all your fever algorithms are obsolete. Just overnight, they're obsolete. So how are you going to do this? Does anyone have any ideas how you might address this when you're using offline applications? Or like if you could dream up a solution, what would it be? All right, here we go. Got one. There we go. Expiration date. Yep, that's essentially what we do. So you have an expiration date on the software that if it doesn't sync online within a certain period of days, it shuts off. But these are the things you're going to have to think about in your digital health tools. And these are not the things that you're thinking about if it's your very first time making a brand new software project. You're not thinking about embedding like a self-destruct into the application if it doesn't sync within a certain period. So then it becomes like, okay, well, what's the period? 90 days, 60 days. It has to be something where it's reasonable. Okay, just to show you that greater than less than errors are everywhere, this is one I found in the AAP guidelines for neonatal cooling. Okay, so these are everywhere. This was one that was like APGAR score of less than 5. For those of you familiar with this guideline, it should be less than or equal to 5. And it notified them when we found this, and it, this has to get changed. So this is published like in pediatrics, and someone was reviewed this like 20,000 times. And still these greater than or less than errors get in. And that matters, right? Because people are pulling their guidelines from this. And if you took your hospital's guideline and make less than 5, it should be less than or equal to 5. It matters. Okay, so a concept to take home here is that errors cluster. So just like medical errors. So in our medical error examples, like 2 people with the same last name, it's like, you don't have to tell me this is going to be a medical errors case. So too with these other areas. It's like when you're going to go and look for errors, you should go and look for them in places where they're most likely to be found. You should spend extra attention to the places where they hide. And one of them is in this. And then we talked about this added complexity of version control, which is another source of errors. So if your app is obsolete, it is now full of errors. Okay. How many, maybe quick thumbs up on the Zoom, how many people are US clinicians here or use a US medical record? Okay, here we go. A few, okay. Okay, perfect. So here's one from our own. This is from Epic. So this was one I took myself when I was working in the neonatal ward. So this was an Epic best practice alert that populated for me in a woman who is 5 minutes away from having a baby. And you can see what it is here. It's saying that this person screened positive for cardiovascular disease screening. And nope, no history of cardiovascular disease, nope, no subjective symptoms, but they had a high resting heart rate and nothing else. Okay, so we're maybe more familiar with these. Anyone want to tell me kind of how they think that happens? Or what happened? Any ideas? Have we all seen these before? Have you all had this happen where you have a best practice alert that populates? Maybe I'll just keep going. So the error here obviously is context, right? This should not have populated. It populated a woman who had a reason to have a high heart rate. Definitely don't need to go and order a bunch of laboratory studies on someone who just was about to have a baby and had an elevated heart rate. Okay, so the error here is that it populates without recognizing that the patient is about to deliver a baby. But the bigger issue is, how would you get this? The intermediate person is like, how would you get this to not pop up? So presumably the computer would need to know that this person's in labor, and they may find that in the problem list, right? They may find that somewhere else. Maybe it's the fact, the location, like the patient's on labor and delivery. So just don't populate this if the patient's on labor and delivery. So it brings up some tricky issues around how do you prevent these. But the expert, I think, gets at this better, which is sort of like, you shouldn't have this kind of alert interrupt you. The error is that a system error for how to use this type of alert. So in this case, the vehicle for how you're delivering the decision support matters, and that's what's missing here. So this is another way that you can have, in my mind, an error, is that you chose to deliver the information, or you chose to have the computer act in a way that wasn't, even if the content was maybe right, that a resting heart rate elevated should trigger a cardiovascular screening, but just the very idea this would interrupt you, there's so many different ways that could happen. Okay, here's a scarier one for people in peds. So I get these are my two US examples of this. So this is a jaundice result in a baby. And what you can see here is that I can click on this link and it will take me to Billy Tool to evaluate this jaundice level for 14 hours. But we see down here, though, wait a minute, it's actually 36 hours. Any ideas of how this, has anyone ever seen this error? And have you any idea how this might happen? For sure, people who do peds, you definitely encountered this somewhere. Any Zoom chatters out there for how you might have this? Have you any idea how this could happen?
I think it's because Billy Tool doesn't allow you to enter data before 24 hours of life. So it might have to do with like auto updating the age to fit that criteria.
Okay, one idea is that it's changing the age to match what Billy Tool is seeking. Any other ideas of how this could happen? How old is the baby, do you think? Are they 14 or are they 36? Any ideas? You can see this one's a puzzler. You can see here that if you click this, you would get maybe the wrong information if the patient is actually 36. So if you click that, it's going to populate the 14. Any other any thoughts on what this is all about? This one was a puzzle for myself as well when I first encountered it, though I knew how old the baby was. So let's okay, dates you're entering is after bilirubin comes back. Okay, so maybe there was a time discrepancy between when you drew the bilirubin when it came back. I like that thinking. Okay, I think here this one was a challenging one, so I'll just go through this. So the junior person is like, I've never seen this before. Yikes! Like, if this is true, then like I don't know what to think. Okay, this is concerning. This is, to me, this one was concerning also. Because what the computer is looking for, right, is the time, the birth time, and the time of the test. And you're going to need to look under the hood to figure out how this could be different in two different places. It smells like a data entry error. And that is what I concluded as well, that whoever put in the 36 meant to put in 14. That's my guess. But you still think the computer would know if you entered an hours number that was older than the actual baby. But for those of us who've used the electronic medical records, it doesn't know that. It wouldn't necessarily know if you put in that, it was 48 hours old when I took this. It's like you'd have to link that cell in the flow sheet to some other logic to know that this was not the case. And this is concerning, as the expert kind of confirms, because you can't expect a doctor to go and confirm every time that the timing of the laboratory studies and the actual hours of life. I mean, this error, one of the miracles was that it was detected at all. Because it has to be like just that perfect kind of shooting star moment where you capture it with your camera to see, like, look, this is the type of error that could just go otherwise completely undetected, and could cause problems if the wrong number is wrong. But one of the things this gets at is the root cause. And one of the root causes is that when you're putting data in, like for those of us who work in medicine, you're putting data into the electronic medical record, and your goal is to finish your day or your task. So you're like, okay, I'm putting this in and I'm putting this in. And you maybe would think of that job differently if you knew that what you put in was going to be acted on by decisions by some software. So that some software is actually going to take what you wrote in and then like recommend things back to you or back to another clinician down the road. So a lot of this, I think, goes back to training. So whoever is going to be using these tools needs to kind of be trained in how to use them. Like one of the examples I mentioned here is, what about if the birth time was entered in incorrectly? If the birth time is entered incorrectly, now all your jaundice results will always be wrong. So then I would ask you, like, for those of you who practice pediatric medicine, who enters the birth time at your hospital? Does that person know that when they enter that birth time, it better be right? Because now all of this decision support underlying is acting on it. Is there a double check for that? You can imagine things like jaundice is entirely, if someone puts in 8 p.m. and they meant to put in 8 a.m., or the reverse, they put in 8 a.m. and they should have put in 8 p.m. Now all of a sudden the baby looks older than they are to the computer, and you'll get a far too conservative jaundice management for the whole time. So this is kind of like the scarier world of, I think, where we're heading a little bit, where what we put in as data can now actually be acted on by the computer. Okay, here's another global health one. This is a preeclampsia tool. And I'll just walk you through it. So 39-week gestation, they've had a prior delivery, they have chest pain, they have no headache, no vaginal bleeding, the blood pressure systolic is 270, they have 2+ urine protein, 98 sat, chance of maternal outcomes 1.3%. Any ideas here? Any ideas of, can we all agree that the risk of maternal outcomes 1.3% seems a little low? Anyone want to just like say out loud what the errors are here? Or the Zoom chatters? How do you think this could happen? This is going to make, this whole lecture is going to make you very afraid the next time you go use the computer. Any ideas of how something that's supposed to literally detect maternal outcomes couldn't detect this one? What do you think? No ideas? Everyone's getting tired of this? Okay, let's go on. Okay, so this is pretty scary. I'll admit that one was pretty scary, right? Because it seemed like of all the things you should be able to predict, it would be this. And I think we can all kind of figure out how these are working, right? They're pulling from like a big data set. They're using math, right, to determine a percentage. If you're familiar with like Kaiser's sepsis calculator, right? It's the same species. It's a risk calculator looking at multiple variables to give you a risk prediction. I think the intermediate person knows that medicine just does not work like this. That these apps are pulling from formulas. If it was only that easy and we could just like put everything in a computer and come back with a risk prediction. The intermediate kind of talks about like a common source of errors, which is that you forget to put an upper limit, which we talked about already in edge cases, right? So if I put in like a systolic of 300, it still would have given me back the very similar result. And it just shouldn't, right? There should be some cap to the limit. But the bigger issue that this one raises is that chest pain, right? So chest pain is like, okay, I've met a lot of preeclamptic people. They don't commonly have a lot of chest pain. They definitely don't have a blood pressure this high. So, and chest pain is like another clinical entity separate from preeclampsia that's going to have to be dealt with once you tell a doctor that this person has chest pain. And the expert kind of gets at this as well, which is that you have a model for one thing, but it's asking for variables that can mean many different things. Chest pain is one of them. The other thing, though, is that this is what most people write about, right? They come up with a model. They're like, okay, we're going to take this model and we're going to make it into a software that people can use to now like apply our model in the real world. And one of the challenges, like that's just not that easy to do. It's not that easy to go from the bench to the bedside with these tools, because in the real world, chest pain, systolic of 270, that's like cardiology stat, EKGs and everything, and it's not a preeclampsia risk prediction. So the lessons here, I think, are about bounds. The case of 1,000-pound baby, we got to make sure we don't have that. I think the other thing is there's a risk with anything in isolation. So if I see an application that's going to tell me, we're going to help you with diagnosing tuberculosis, and say, okay, I get very nervous about that because I'm like, how are you going to separate that from lung cancer? How are you going to separate that from COVID? So narrowness can actually be a source of errors or siloed thinking. One of the challenges you have in any digital tool, I think, is to make sure that that tool should be applied to, if you think of it like a medicine, who should get this medicine? It's like, okay, well, I need to make sure that whoever starts this application is sort of in the right classroom. And we talk about this in our work a lot. It's like, what if someone opened up like this pathway, but they really had like a totally different problem? This is maybe the extreme example. Is like you have a left arm clinic and someone walks in with like a myocardial infarction. How are you going to like make sure that person like, oh, no, sorry, you're in the wrong area. You need to actually go to cardiology. So these are the things that we think about a lot on the digital health side. Okay, so what have we learned? I would say a lot of scary stuff if you're in this field. Yeah, that's right. The AI is like even crazier, because it's like what someone mentioned about AI, but it's like, yeah, how would you know? How do you even detect what went wrong to then go backwards? So we saw a bunch of very scary errors, and hopefully learn to become a little bit better at detecting them. And what I would say is one thing I've learned is like if you find one, you will find others. So just like a hospital that has like 5 medical errors, very bad ones, it's like, well, we definitely have then a lot of kind of bad ones and probably thousands of like near misses. So this is always the tip of the iceberg. Something I have tried to share in my own work is that we think of software, especially in global health, as like, this is going to be good. This is going to be like a tool that's going to help us. We used to have to print stuff. Now we're just going to like beam it out. The way I would explain this is software can reduce errors, it can amplify them. So, you have an error in a pediatrics publication with a less than sign. That's not so bad as an error where that's like encoded into a decision support that everybody is now using across the world. So they are amplifiers of both good and bad. They're scalable. So we need to be extra careful about the versions and getting it right. The last thing I'll mention is for those of you in global health, these are being deployed in places where errors are going to be harder to detect, where people who get harmed by tools have less legal recourse, and it may take longer to identify that there's even something wrong with it. So that's all the reason I would say to be more careful in a global health context. So maybe with that, I'll say thank you for playing, and happy to take any questions. Are there any questions at all out there?
Hi, this is Barbara Weiss. So I've been thinking about a lot of these lectures we've been listening to are all the innovative technology people are using in the global health field. So now it's making me wonder about some of them.
And I should just say, because I didn't introduce myself, our group works in those innovative technologies. And so I'm like a total believer in them. At the same time, that's exposed me to them. So like I get to play with a lot of them. I get to meet the people who made them. They're rarely medical people. And so it gives you pause. I think one of the things I think because I live here in Silicon Valley, near in the same area as UCSF, and just like we forget, like the software we are exposed to is like elite. It's this software that's like Google Maps. Like, have you ever had Google Maps take you to the wrong place? You know, thousands and thousands and thousands of times. So then you just assume like, okay, well, software kind of works like that. Like it doesn't always. And medicine is really, really complicated. It's more, so to me, yeah. It's just I hope this was something that you can apply to your work. I worried when I was coming up with this, like, geez, is this relevant to anybody else? But I came to the conclusion that it will be relevant to you, even if it's not relevant yet. You're going to be using these tools and trying to figure out, okay, is this a good one? Okay, I'm looking to see if there are other questions. Any other questions at all?
I think this is both enlightening and I echo what Sharm said.
I know I originally had like a Halloween graphic for this thing. I should have kept it. I had this like scary Halloween icon because this is gonna, even the epic ones, right, are a little scary.
I just want to say too, we did put sorry, I said Jeff, but Josh, sorry.
Yeah.
We do have a survey, a short survey, and that takes like 2 minutes to fill out. We really do appreciate your feedback for those in the chat. And then I was wondering if this kind of is a slightly different direction, but what, you're a pediatrician and you're a clinician by training. How do you see these two worlds that you are so involved in, both the tech and kind of the like innovative space and the clinical piece that you do, and kind of what was it that drew you to the technological pieces of medicine?
Yeah, that's a great question. I made my own journey in global health. The thing that drew me were babies. So babies are like a specialty that is also extremely common, right? There's no other thing that's like, it's like a specialty, like adult rheumatology, but it's like, but everybody is one of these at one point in their life, a baby. So I was like, okay, this is a problem of scale. You're never going to have enough baby specialists. So this is going to need a scalable technology. And that's what led us to digital. And then I also felt like drug dose errors, which actually surfaced in this talk, was another thing that drew me. I was like, people are not good at drug dose errors. So technology should be better at calculating drug doses. And one of our first innovations was a decision support for neonatal care that included contextual drug dosing. So for me, it's like we need these. We need these tools to scale some of this care at a global level. But I think one of the things that there's many times when I'm in a room about this topic and the only person who's ever taken care of a baby, and so then it's like, okay, one of the things you can bring is like your unique perspective on like, okay, look, when I see this, I do that, and I know that's right. So you have to make your technology match this. It can't be not matched. And the example of like the 32-degree temperature, right? Like, let's just take that as a baby born at home, comes in by ambulance, 32-degree temperature. It's like totally believable. You could see that case last week. So then it's like, okay, when I see that, here's what I do. I tell them to put a warm blanket on the baby. We got to get that in there. Otherwise it's wrong. And I think the other thing that happens, the other thing that's, I think the medical training brings is just the humility of how hard medicine is. Because you're like, okay, look, this is not going to be easy. And we have to be like double, triple, quadruple checking everything. The vital sign logic is like a classic for that. It's like, okay, look, I could fool your app 1,000 ways with the just simple vital signs. Whereas in a clinician, or people, pediatricians, you look at the vital signs and your brain's like, yep, normal, or oh, abnormal. It's a super quick reaction. So anyway, that's a little bit about how I got into this. And I think where clinicians can play a role is in informing the discussion around this stuff. Yeah, it's important to have clinicians involved. I think that's one of the things I completely agree with that. Especially as the care gets more complicated. Any other questions out there? Was this relevant to anybody's work, or is it just sort of like, no way, this is It was relevant. Okay.
Are there opportunities at Global Strategies for internships or ways to get involved?
Yeah, I would say if you are interested in the very specific topic of clinical decision support, where you're thinking about, okay, I want to design a tool that's going to help a clinician do a thing, who maybe didn't have formal training in that area, that's an area that we're like deeply, deeply involved in. Those are all the examples I gave today. So they're all fall into that class of software. There are other classes of software that deal with health. But that's an area, yeah, if anyone's interested in that, for sure, reach out.
Would you mind putting your email in the chat if
Sure,
people
yep.
want to connect with you?
Oh, sorry, dropped the F on. There's no F on that, but yeah. Any other questions or comments? Yeah, I never thought of it. This is like if you do a lot of lectures and when you're in med school, you hear those people say, oh, I have a career that wasn't even like a career back when I was in med school. That is in some ways this type of work. Thinking about software. And I think a lot of the innovations, the best innovations are going to be, software and medicine combined into something where you have experts from, but what people call it cross-disciplinary. To me, that's really the exciting areas. I always tell people like the worst software I ever see is ones made by doctors. The second worst are made with no doctors. And then the best are ones where it's like, okay, you could tell someone was like looking at the back end of this. A good example is I had the things I like Kaiser Sepsis Calculator, right? That was like a highly impactful software. You can't trick it. Like I would challenge anybody to go and like try all the things I showed you today to come up with a case where that gives you the wrong output, and you won't. Now, partly because it's a much simpler application, but it didn't make the same mistakes as the preeclampsia calculator, right? Telling you like things were fine. And it even has this thing where it's like, you have to decide what the clinical situation is. You have to decide if the baby's sick looking, maybe sick, or looks totally fine. And it never tells you that. So it doesn't make the mistake of the app that said, stop breathing. Just takes over what the doctor should do. It makes the doctor say like, okay, look, I think this kid looks fine. Okay, in that case, the risk is 1.2%, whatever it is. So a lot of these are, enhancing the physician, right? They're like physician enhancers and not replacers. To the Barbara's comment about like AI taking over, it's like, oh, I'm kind of more interested in the technologies that make me like more powerful doctor. Kaiser Sepsis Calculator is like a great example of that. It's like, I now have this new power. I can tell you the mathematical chance of sepsis with, to the parents, right? That's like a great new superpower that I now have thanks to this technology. And it was only me who could wield it because I needed to know if the baby looks sick, which is in my training. So it's going to be a long time before like, AI tells us like that baby looks sick more than a human. That may be like one of the last things AI takes over, right? So it's like the ability to like look at a sick baby. It's like it's hardwired in our genes to do this. So it's like, parents can do this who have no experience. So I think that will be one of those areas where like sick appearance, just as an aside, sick appearance is one of the most interesting variables to me because it's like a vital sign. It acts like a vital sign in the computer. It completely shifts your thinking on this, but it's something that only the clinician can do. I think it'll be a while before any technology comes that can do that. To say like sick appearance. But what's, if you worked with parents and sometimes parents will say, like, how will I know if the child is sick? That's like a common question that pediatricians get. And when I see a parent ask me, I said, look, if someone's sick was walking towards you across the street, you would pick them up at like 50 yards away. And you would cross the street because like, that person's looking sick, I'm heading to the other side. So your brain has like all these amazing tools to like identify illness. And that's what you will use. And that's why parents can have this like sixth sense of like, wow, I had this feeling like my child was sick. Like, oh, they looked fine to me, but then it grew out GPS. It's like the parents had this ability to detect. So the clinician too can like, why would you throw out the clinician? They're super valuable. They can tell you who's sick looking, and then you can sort your algorithm by then. They can also tell you like what the, I always think of like a case that'll be this is kind of more discussion, fireside chat, but a case that'll be very hard for a computer. Chief complaint, I am sad. It's like, okay, that would be very hard, right? The underlying algorithm would be just gigantic on our back end because we have to sort out like who is sad because they had like a legit reason for being sad, who is sad, or you now have to like admit them for concern for suicide. So these are like the things where it's like, well, wow, we're never going to solve that with a computer. It's always going to be a combined computer plus. That to me is like the sick appearance. It's like the ability of a person to like just help the algorithm move through to where it needs to be. And I'm sad is one of those where like, oh yeah, that would be like almost impossible for a computer to do. Where a human would be like excellent. So too with sick appearance. So these like other variables like that. ER doctors are great to talk to because they have to make these decisions all the time. And they'll often tell you like, yeah, I just had this like sixth sense, like I got, worried. And I'm like, okay, some of that is like what people call gestalt. Like it's not recommended. Don't practice medicine by gestalt. But then the other thing, when I hear that, I'm like, okay, so you like applied some human thing to this. Like, what was that thing? What, let's like dig into that and figure out if we could somehow bring that out. Especially if you're good at that. Yeah.
That's so fascinating. In ICU, we call it the spidey sense, but that's
Right.
probably
Sixth
trademarked.
sense,
but-
spidey sense, right? And sometimes that
Yeah.
can be bad, right? It's like influenced by previous cases. But sometimes it can be very good. It's like there's something that I'm sensing.
Yeah, that's really interesting if you can like make that an objective marker. That I would add to mental status to like the sick thing, which takes kind of a clinician, like you need some kind of
Right.
level of like training to, but mental status is like a very ominous sign if it's off.
Right. It's like, is the person confused? And it's like, okay, that's something only the
Mhm.
human can figure out. Yeah, and it's funny because mental health is an area where people are applying a lot of digital health tools. And so, screenings, and it's going to be an interesting area to watch for sure. My own sense is like when I first started this in global health, a lot of the problems were simpler, right? Like I remember attending lectures on bed nets when I was in many of the trainees here. It's like we're gonna like put a bed net over the house and or over the bed and clean water. And these are like all critical interventions. But for me, like what I saw when I was doing my global health field work in Eastern Congo was like, okay, yeah, no, it's none of those things. It's actually babies. Like babies were the #1 cause of mortality. It wasn't even close. It's like babies are not like bed nets. They're way, way more complicated. So this is going to take different types of tools. And if I look at some of the lectures that people have been talking about, like I attended a lecture the other day on antimicrobial drug resistance. And I'm like, okay, yeah, try solving that without a computer. This is going to be like impossible. So one of the things that I always look at when I look at global health problems is like, what is the tooling that is needed to then build solutions on top of? That's something I've learned in the digital world. So what platforms or frameworks or whatever tools that we're missing so that someone could like really quickly make an antibiotic, like the antibiogram, whatever it is. So what are the ways that we could quickly update a guideline in response to new resistance patterns? What are like the underlying tools? When we talk about our own work, I often say, when I'm in global health, I see a lot of shows and I rarely see a Netflix. It's a rare day that I see something that's like a game changer platform. They're all one-offs, and so for me, some of these challenges, you just have to be clear-eyed about how big this problem is. Like, neonatal mortality. This is a huge problem. It's not going to be solved by like a one-off anything. It's always going to take some big platform technologies. Like a group I'm interested to watch is groups working on like oxygen delivery systems in low and middle income countries. I'm like, okay, that's a platform. I'm like, if you could solve oxygen, that would be cross-cutting. It would hit COVID. It would also hit newborns. There's a risk in newborns, right? There's like, but that's something I'm like, okay, that's something I'd want to be a part of if I was in your shoes as people in trainees, as opposed to one-off interventions. I'm sorry I had to reschedule this, but I'm excited we at least had a group here, and hopefully we picked up a few error detecting hints.
That was great. I really appreciate it. And thanks for being flexible with the rescheduling. I was just thinking maybe next year, if there was a way to have you in person to like get hands on some of the tools, that could be really fun.
That's actually fun. Human factors. It'd be a great lecture about that and how you test a brand new thing.
Mhm.
I actually need some human factors volunteers. So yeah, maybe 2 for 1 there.
There you go. Thank you so much, Josh. Really appreciate it.
Thanks,
Always good to
everybody.
see you. Take care. Bye.